I will present the case of a patient that requires ultrasound-guided percutaneous transabdominal embolization of type 2 endoleak. I decided to make a background about the subject, and then I will present the case just to make an emphasis in the treatment that we apply. First, we have to have in mind that type 2 endoleaks are a frequent complication following a reparation of abdominal aortic aneurysm, and that occurs in 10 to 40% of patients. Most of them don't require secondary intervention, and the course of the disease is benign with a spontaneous resolution in most of the reports of the cases on the literature. And persistent 2-type endoleak could result in aneurysm enlargement with a big possibility of rupture, and that's important event that requires a timely treatment. So I'm going to describe a case of an endoleak following endovascular repair of abdominal aortic aneurysm treated by embolization of lumbar arteries using a transabdominal embolization approach using color flow duplex guidance. A 78-year-old man was referred to the vascular surgery service with the antecedent of the repair of aortic abdominal aneurysm 3 years ago, and then he presented a 2-type endoleak in the angiotomography control. The first was diagnosticated 1 year after with a transverse diameter of 61 millimeter and anteroposterior of 44 millimeter. The next control was on the next year with an increase of size. We have a diameter transverse of 70 millimeters and anteroposterior of 60 millimeters, having an increase of 10 millimeters approximately. He has asymptomatic in all follow-up time, and he doesn't have any comorbidity. Because of the new size and the persistence of the endoleak, we decided to treat it. In the tomography, we show that the sac is becoming opacified through the vessels of the lateral side of the aneurysmal sac, which denotes compromise of lumbar vessels due to the angiotomography location. Over the guide where a 5 French angiography catheter was placed within the endoleak site, an angiogram of the aneurysm sac was performed to evaluate the region of on-off flow on the endoleak. The endoleak sac was punctured by anterior transabdominal access using a 20-gauge puncture Shiva needle under color flow US guidance through the anterior wall of the abdomen of the patient. You can see the red arrow pointing the inferior epigastric artery and the black arrow pointing the direction of the tip of the needle. After confirmation of arterial blue following through the puncture needle, so here, we can see the puncture needle, and we can see the flow. Next, the guide wire, a microcatheter is advanced, revolved Medtronic, and was placed within the sac of the endoleak, and the angiogram of the aneurysm sac was performed to evaluate the origin and outflow on the endoleak. Embolization of the endoleak sac was performed. The aneurysm sac was embolized using the liquid embolization system called Onyx that fed and went towards the vessels that produced the endoleak. The endpoint of the procedure was the non-visualization of blood fluid within the aneurysm sac, and technical success was defined as successful embolization of the endoleak sac. Clinical success was defined as complete resolution of the endoleak and the asymptomatic patients during the following way. I'm showing the image about all the procedure. To make an introduction for the subject, we have to remind that the management of the type 2 endoleak is controversial. Most common treatment is embolization, and most common approaches are transarterial and translumbar direct sac puncture. Technical success appears in 55 to 100% of patients, being the transarterial embolization of lumbar artery is the procedure that has the lowest technical success. Clinical success appears in 15 to approximately 89%, defined as freedom for aneurysm expansion, but we have a very limited long-term data of case reports and studies in the literature. On basic concepts, ultrasound guides transabdominal direct sac puncture is an alternative to the approach for 2-type endoleak. Because of the limited literature, we don't have the possibility to make a comparison about other embolization approaches. The access was in real time to the anterior abdominal wall, and the embolization performed under fluoroscopic guidance. On the other hand, many authors have published the easy course of the 2-type endoleak due to the fact that the majority disappears spontaneously without any treatment during the following period. And for us, the localization on the endoleak was really important because that dictates the adequate access of the case. Also remind that in the CT angiography, the sac field depends on the site in the engage. For example, if the sac fields on the anterior side, we think about the compromise lateral of the mesenteric artery, and the same happens with the lateral side that compromises the lumbar arteries. Or if it fills the posterior side, we think about the compromise of middle rectal artery or an accessory renal artery. Finally, this access is technically feasible when performed by experienced operator, also shapes similar clinical success and transarterial approach with limited literature that we have. The other point is that requires significantly shorter fluoroscope and total procedure time, less radiation for patient and staff, and less sedation is needed. The real limitations are the lack of long-term follow-up and the small sample size. At the end, in conclusion, this treatment is technically and clinically effective. We have to be very conscious about the risk of the puncture of the intestinal structures, and we have to visualize them very well to avoid accidental punctures. And now, in our experience, we prefer this approach to treat this type of endoleak because it's more effective in cost and it's shorter in time, and we receive lower radiation with a very good result for the patients. Thank you very much.
Do you have the follow-up CT after that?
We don't have, because the patient was living so far, so we don't have the CT control. But we called him, and he told us he's very asymptomatic and everything is okay with him.
Mm-hmm. So what made you pick translumbar as opposed to transarterial, or even now the newer one they do transscalar?
We can do.
Why did you pick lumbar?
Why we don't do
She
this?
did abdominal.
Yeah, abdominal. So why did you pick transabdominal? Why did you
Transabdominal was because we saw in the angiotomography that the distance in between the wall and the
thinner person
was approximately 5 centimeters, and translumbar was more like 15 centimeters, and we didn't see anything between the wall and between the sac, and we decided to do that. That was the reason. We have an experience before and was very good with the patient too.
And then why onyx?
Onyx, we use it in Colombia. It's perfect for us.
Perfect, okay.
Available. Did you see any outflow vessels there? I didn't see the angio.
No, it's a simple endoleak. So only we make the cannulation of the endoleak, and we just see the only one vessel.
Sac only.
Yes.
Great, fascinating. Thank you very much.
Thank you very much.
Thank you.